We use a variety of terminologies and through the years try to come up with the right diagnostic criteria for decompensated heart failure. We struggle with this. So my intent right now is to demonstrate to you what trajectory I'd like to move the field towards with your help, with all the experts' help, for us to do this right. Because currently we're just scratching the surface of how to define decompensation, how to target success for treating decompensation, and how to create the phenotypic characterization so we could apply the right treatment strategy for the right phenotype. And this lecture right now is going to have a variety of components for the concepts, some on the hemodynamics, so a little bit of a switch in gears, but this is going to be a first step in a collaborative, I guess, commitment that we should make a change. These are my disclosures. So the current acute heart failure, and I'm going to use a lot of terminologies, entails a syndrome with symptoms and signs, and sometimes defines the de novo as the new onset, and sometimes worsening of pre-existing heart failure. Severe enough for the patient to seek a higher level of care. So that's usually the second criteria, that you need to go somewhere to get that advanced care. And that's usually specified by a location to the hospital or urgent care. And the third component, which is the component that I want to focus on, that should define the decompensation, is the elevation and the escalations of treatment. That's the delta. That is what currently should define the decompensation, but it doesn't, because we tend to combine it with the former first and the second. And if we look at what do these mean, the black brackets on the right side, the first one is patient is worse, the second one is location, that brings the patient being worse, and the third one is we do something, the treatment, that justifies the higher level of care. The guidelines, and I know that is pretty complex, have struggled with these, and you could, in your free time, try to read the text, but all it matters right now is for me to state that, yeah, we struggle with this. In the US guidelines, we actually define treatment for heart failure that comes to the hospital as recommendations for hospitalized patients. So we have it by location. That's not the right way to do it, probably, because we just didn't have the right formulation for this. And other guidelines and or decision pathway documents by consensus statement usually entail those 1, 2, 3, meaning worse symptoms and the location, and then you're doing something higher. If we look at the clinical trials, interesting things are evolving. And the names on the left side are the most recent heart failure clinical trials. And I'm going to emphasize, trial inclusion criteria are different than endpoints that look at decompensation. So we're going to try to differentiate those. At the trial inclusion, we usually look at the diagnosis. That is usually done by the clinician and or an education committee. And if you look at what criteria were included in most of the heart failure trials, they differ. For example, in Pioneer, primary diagnosis of heart failure, including symptoms and signs of fluid overload. Another study called Galactive, looking at cardiac myosin activator, currently hospitalized for heart failure or a visit to the urgent care for primary diagnosis of heart failure with elevated natriuretic peptides. So they're adding a little bit of a more objective diagnostic marker. Other studies with SGLT2 inhibition, Soloist with the SGLT2 and 1 inhibitor, and MPulse with an SGLT2 inhibitor, admitted to the hospital or urgent care visit to ED, or an infusion unit for worsening heart failure associated with evidence of volume overload and receiving IV diuretics. So in essence, in this formulation, there is a permutation of adding the treatment or requirement for the IV diuretics. The concepts are, as I said, varying, but again, making our construct for clinical trials a little bit more challenging. In the heart failure event as an endpoint for adjudication in clinical trials, we tend to be more specific. So not only are we looking for the diagnostic criteria or the diagnosis of heart failure, either by ICD-10 codes, we're looking for presence of symptoms and signs. We want to see it in the chart. And we also are looking for diagnostic objective criteria such as elevated natriuretic peptide levels or imaging, right? We want to see that in clinical trial adjudication. And we want to definitely see treatment, escalation of treatment by either IV diuretics or vasoactive treatment, or in the recent trials, we're accepting, of course, mechanical circulatory support and other interventions. Does the acuity matter? For those who come to the hospital or urgent care, we know that not everybody is acutely decompensated. 1/3 acutely, 2/3, depending on the population you're treating, is a gradual decompensation of the chronic heart failure patients. How about the de novo? That terminology is used first ever. So bad that they are decompensating and coming to the hospital. That's not every patient. Not every de novo patient is going to be requiring hospitalization. Quite a significant proportion of those are going to be seen in the clinic. So if de novo is not decompensated, it would not be acute heart failure and would not suffice a terminology. And if we look at the recent heart failure journey, if you look at the clinical trials, we've used the hospitalization to increase the risk profile of our patients. And the trials listed on the right side actually do incorporate patients with history of heart failure hospitalization. If you want event rates to be higher, yes, you're going to be targeting currently hospitalized. Those are the right lower panel of studies. So in essence, it's a strategy. Looking at the acutely hospitalized patient is a strategy from the heart failure perspective to enrich the risk for us to be able to demonstrate high event rate. Otherwise, it's a journey, it's a continuum. And some of our chronic outpatient heart failure trials actually entail patients with repeated hospitalizations, and they have high risk too. So we recognize de novo by itself is not adequate. Acutely decompensated or decompensation of chronic heart failure are not easily captured by acute decompensated heart failure. Then raises the question whether do we need the word even acute. The common denominator for all of these terminologies is a decompensation. What does decompensation mean? It's not just hemodynamics, it's not just a journey, because you don't want to look just at a delta of a BNP or a delta of a cardiac index or wedge. We know that's not going to work. It is a requirement for escalated therapies, which all of you in this audience is very aware, the phenotype that requires the escalated therapies. That's the component that will define the decompensation with the formulation that I'm proposing. This is a journey, and again, this requires a consensus building. We're at the early phases of this consensus building. I have been socializing this concept with experts, and you're one of the other audience members. Just keep in mind, this is not a reflection of AHA, ACC, HFSA, and this is, in essence, a conceptualization we've been discussing with experts in the field to see whether we can mature this concept enough for us to develop consensus in the community. So the proposal that I have for all of us is that decompensated heart failure in the new era to be termed as heart failure patients with a need for intensified or escalated urgent heart failure therapies that could be IV or mechanical or other advanced therapies, the location of which may not matter. You could be doing this in the urgent care or in the hospital or maybe even at home. We have hospital at home. And thus, we have seen it during the COVID time, what we can achieve with virtual care. So the first step is the concept of what we capture as decompensation, which I think we need to develop a consensus on. And maybe the terminologies we're going to use is patients who are refractory to standard or optimization of heart failure therapy and with active deterioration who require this intensified, escalated, sometimes urgent, or advanced or rescue heart failure therapy, not specified by location or requirement for hospitalization. What do I mean by this? We have seen from hemodynamic studies, and there's quite a few, this is from comprised trial, which looked at what's happening to the filling pressures. We know worsening happens prior to the patient hitting the hospital. During that worsening period, there is a time frame by which the clinicians can adjust the oral. You could be optimizing GDMT, the guideline-directed medical therapy in heart failure. And yes, you can reverse some of the patients. But then there are those who will not respond or be refractory, or whatever we do is not going to be adequate. That's going to require the higher intensive escalated therapies. That's the part that I'm trying to capture by what I name as decompensated. It's not just worsening. Worsening, you can entail interventions in the outpatient setting, and maybe you can reverse that. But decompensated requires the bigger guns. The step 2 I'm proposing, which is in line with, of course, the conceptualizations that have been developed before, is phenotypic classification, or treating according to what we think we can do. And the former permutations for this, spearheaded by Mihai Georgiadi and others, looked at, of course, the typical phenotypes: pulmonary edema, the shock, the RV failure alone. We recognize those require specific approaches. You're all familiar with this. I'm not going to go into that. And maybe we need to define those, but I'm trying to make it a little bit more simpler because I want to create this congruence of what the ED physician will be able to do, as well as hospital medicine, hospitalists will be able to do in the inpatient setting, as well as a specialist. And I know by the time you all are called, we are dealing with a very higher level of care. But let's look at the early phase. And we also know that even in the shock, we have the overlapping phenotypes. We know the SKY classification, when we went through the last permutation, is looking at the gradients, the shading, because the delta changes of what happens to the patient during the time when you're intervening also matters. So we're going to talk about those delta changes in a minute. The concept that we keep struggling is we use terminologies for prognostication. SKY definition right now is, in the shock domain, is a prognosticator. It's coming up with good guidance of what to measure and be aware of what the delta changes are so you can make sure you could intervene in a right or timely manner. But I think we just need to simplify this a little bit further. The concept that it has been proposed by Stevenson and others in terms of the congestion and perfusion paradigm, the left side. You know this quite well. The congested with good perfusion, which is the majority of our patients, warm and wet. That's the majority. I actually think that rather than having the 4 quadrants, the 4 permutations, I think we need to make this simple. Congestion versus perfusion. So congestion versus hyperperfusion, and we should simplify the triage at the time of the classification for the decompensated heart failure. So decompensated is those who require escalation of therapies, and then we're going to look at C, congestion versus hyperperfusion. And for the congested, of course, we're going to decongest. For the hyperperfusion, we're going to try to achieve perfusion. And in the congested ones, one can look at the pulmonary edema separately because that creates an urgency for intervention. It's It's the rapidity by which you need to decongest for you not to lose a patient in the ED. And I'm making that similar to the ACS story, meaning, STEMI, yes, you have a certain door to balloon time. So in congested pulmonary edema, you in the ED should be able to do the IV diuretics within the first 60 minutes. So that concept, congested pulmonary edema, do decongestion in a rapid manner, and then the rest with either the target of achieving a good delta change. And we're going to go over this. What do we mean by the delta changes within the first 3 to 4 days? And I don't need to go through the permutations of how we define this, but we're trying to come up with some standardization of what do we call for, pulmonary edema versus pulmonary congestion versus systemic congestion. But we probably need to define these for our clinicians. The hyperperfusion, which I know is dear to all of yours hearts, I'm trying to simplify it in the heart failure world as pre-shock versus the shock. Yes, the end organ damage and requirement for restoration of perfusion. And of course, this is well known to you, but we're trying to make this simple for the ED physicians and the hospitalists. And yes, it may entail some lab markers, maybe hemodynamic characterization, and some perhaps recognition of what's happening to the end organ. The third step that I'm proposing is define the specific etiology, phenotypes, and the proximate cause for decompensation. So, of course, it does matter if the decompensation is due to an MI or an AFib with the RVR or other kinds of entities such as myocarditis. So if you can define that, it's critical because then you may need to do a STEMI care, right? The proximate cause matters. And, of course, you're going to look at the usual confounding, competing diagnoses we deal with heart failure. It could be pneumonia, it could be COVID, and all the others. And the second component is specify the ventricle type. Is it RV alone or BIV, which is a common one that we see. And this one is important. Define the specificity of a presentation that requires specific therapies. Decompensated heart failure with respiratory failure. Decompensated heart failure with diuretic resistance or refractory to decongestion. Decompensated with repeated episodes. That's the long-term trajectory, which I will show in a minute. Diuretic resistance is important, and that's the delta change. Either you're defining as an outpatient that you already know, or within the intervention that you're doing in the hospital. Yeah, low urine output and or inadequate response for what you expect in that patient. There are a variety of other physiological and functional parameters listed in the middle domain. We don't know how to define this well. Dan will ask me, how do you envision this being standardized? We don't have a standard way. I'm going to go over this because I don't think we can have one size fits all. That's the problem we're dealing with when we're looking at refractoriness or decompensation. Step 4 is trajectory. So this is the trajectory after you have defined a decompensated heart failure patient and you're intervening for decompensation. You're doing the intervention for decompensation. Now, the successes here are unfortunately confounded by administrative issues, because in the hospital, we do have the length of stay and administrative requirements to discharge a patient. That's why I am very passionate about us changing the paradigms so that these individuals who require advanced therapies and continuation of decongestion are not pushed to discharge. So the top part is the important part, patient's perspective. Yeah, patient wants to feel better and doesn't want to come into the hospital, but also wants to live longer. The system issue is, unfortunately, right now working against decompensated heart failure. Decompensated heart failure right now, treatment is a Band-Aid. The patient comes in, gets a intervention for decongestion without much of a really reasonable change in their trajectory, and in usually 3 to 4 days they're discharged. unless they're on some mechanical circulatory support or ventilatory support, or some continued IV therapy. Otherwise, utilization management is not going to allow you to keep the patient in the hospital in the United States. So we are not able to treat the decompensation effectively, not that we know exactly what the standard therapies are, but because we cannot define these patients. And of course, the physicians want to be able to target all of the above and are at the crossroads of complexity. We're dealing with the administrative rules and regulations. So let's look at what do we consider for success. Well, all the dyspneic patients, when they get into the hospital, as soon as you put them in the bed and put oxygen in or give diuretics, the dyspnea usually gets better. That's 75 to 85% of the patients, even in the placebo arm of clinical trials. The standard therapy will reduce the dyspnea. And if you look at the signs, 2/3 of the patients will have resolution of their JVD and RALS. You may look at it from the glass half full and glass half empty, meaning 2/3 improve, 1/3 doesn't. 1/3 has residual JVD. They may be living with chronic JVD. So how do you target therapy to? Those with biventricular failure with persistent JVD, you're not going to have total resolution. So we actually individualize. And about half or 3/4 will have resolution of edema at discharge. And if you look at the weight loss, I have a magic formula for this. In the US, it's 1 kilo per day. Okay? And so if the length of stay is 3 days, it's 3 kilos. If the length of stay is 4 days, it's 4 kilos. Because we try to target this, gestalt of -1 liter per day approach, usually, in the clinical trials. But in real world, that is actually much less. The things that we struggle with is there's no apparent correlation between weight loss and dyspnea resolution from the clinical trials. So this concordance of symptom improvement and sign improvement is not coming together well, but the more, the better, and I'll show the data. Weight loss alone is not adequate, is not associated with long-term better outcomes. Weight loss alone is not a good surrogate marker. And PA catheter approach, we know in the ESCAPE trial, when you target the hemodynamics, but mind you, these were not shock patients, and these were not with markedly elevated filling pressure patients. I mean, if you look at the delta changes in the pulmonary capillary wedge pressure in ESCAPE and VMAC and other studies, it's very small. The delta changes are small, and the baseline is 20s. This is not a wedge of 35 overall. So we know what we do for our patients, but the things we don't know is sustaining that. Now, with the, of course, remote monitoring, we're going to have better data. If we were to target natriuretic peptides, we're not talking about hemodynamics right now. If we were to target natriuretic peptides and tailor therapy to natriuretic peptides, so chasing the natriuretic peptides, this is a chronic heart failure study, GUIDE-HF, randomizing to usual care with very good optimization of guideline-directed therapy versus chasing the natriuretic peptides, you're unable to demonstrate a better outcome. What does this mean? Treating the natriuretic peptide by itself, treating a number, does not result in better outcomes. This is for chronic or ambulatory heart failure patients. This is for acute decompensated hospitalized. Very similar. Chasing the natriuretic peptide in a clinical trial, because what are you going to say? What is the target? In GUIDE-HF, it was reduced the NT-proBNP to less than 1,000. So somebody who came in with 400, they can be discharged with 400, right? Somebody coming in with 3,000, how are you going to get it less than 1,000? 3,000 doesn't come down to less than 1,000. 3,000 goes out with 2,000. So we know this, but the trial designs were not able to be tailored for the baseline. Though I will tell in a minute that there were attempts for the 30% reduction or percent reduction. What we know is those who get better with guideline-directed therapy, actually, those who get better with therapy, those who are demonstrating improvement, their levels come down. So it is a marker for improvement and responsiveness to therapy. So we see, for example, this with ARNI. If you give ARNI, NT-proBNP levels come down. This is for hospitalized heart failure patients. The things we know, more complete. Remember I told you weight loss doesn't correlate with outcome benefit. Dyspnea resolution doesn't correlate with outcome benefit, but more complete decongestion associated with better outcomes. We know these weight loss and fluid loss and reduction with NT-proBNP was associated with better outcomes. 2 or 3 markers of decongestion, especially when you have an objective one along with symptoms, is associated with better outcomes. By themselves alone, each component is not. But if you combine the symptoms and signs with an objective marker and achieve more complete decongestion, you start seeing some signal for improvement. The other side of the coin, incomplete decongestion, residual decongestion, is associated with worse outcomes. But the thing we don't know is that a reflection of sicker patient refractory to treatment or inadequate treatment? Probably it's both, because as I told you, we tend to treat episodic administrative targets in heart failure care in the United States. It's a length of stay mostly, and you try to just achieve some improvement in the symptoms. As I told you, even placebo achieves improvement in dyspnea. So most patients will be discharged with an improvement, feeling better, breathing better, a little bit of weight loss, and not really a clear guidance of what the target was for that patient. So my proposal is for the success for target is individualized, and how we're going to do that in a clinical trial design is not formulated here. But I know at the bedside you all are doing this. That's why we do it. We need to optimize according to what we think is the baseline and what was the decompensation, and we're trying to go to baseline and actually do a disease modification and change the trajectory. So yes, we need to have the improvements in symptoms, signs, and some diagnostic criteria. So I'm approaching this holistic approach of 2 or 3 or more of decongestion is better than any alone. Now, this is a busy slide. I started experimenting with this with my learners, with my trainees, as a handoff tool, because, we have different providers in the US with, hospitalists and advanced practitioners. We want to be able to tell the story of where we want to get to. For a patient that is coming in with 10 kilos of fluid retention in the last 6 weeks, I'm not going to discharge that patient with a 1 liter negative fluid balance, okay? Or I know that patient didn't have JVD at baseline, but now has JVD. I know that resolution of JVD may be the target, but a patient with biventricular failure with always a JVD, I know that total resolution of JVD is not going to be realistic. I know that those who live with elephantiasis, with fibrotic changes of edema, with lymphatic drainage abnormality due to obesity and congestion, they're not going to have normal or resolution of edema. We all know this. The trainees know it. Everybody knows it. So how much? How much is the right target for discharge? In the United States, again, I'm emphasizing it's never individualized. It's only administratively dictated, saying you need to discharge a patient in 3 days. So it is right now mostly a placebo care. So maybe this may allow us to achieve other things very important for all of us, because I find the false alerts very problematic in hindering, hijacking care and clinical trial design. This is the acute kidney injury concept, the rise in creatinine, AKI. There is an epidemic of coding for AKI in the world, predominantly in the United States. Why? Suddenly we started having a flurry of kidney injury, kidney toxicity, despite us having more, perhaps, kidney-preserving therapies. No. We actually reimburse for AKI. We incentivize AKI. AKI is a reflection, probably the simplest reflection of complexity right now. Simplest. Any rise in creatinine can be coded as AKI, and it is being coded like a pandemic entity. In the nephrology world, the graphs, I don't have them over here, of the coding for AKI, the trajectory is much higher than anything else. It's higher than pneumonia, it's higher than heart failure. So what does this mean? When a code is done in the United States, for it to be reimbursed, it needs a treatment or a strategy. Something, you need to do something. That's the utilization criteria. If you say AKI, you need to say, I'm going to do something for AKI. So the common thing that is done for AKI is stopping heart failure medications or decongestion. So you can imagine how problematic this is. Why am I showing this slide? Rise in creatinine with successful decongestion is not associated with worse outcomes. You all know this. I am not talking about a shock patient going into renal failure, that you have to do mechanical circulatory support. I know that's the concept you're thinking about. I'm talking about the patient with biventricular failure. When you decongest, may show a sign in rise in creatinine. I'm going to tell you that that same patient may actually have improvement in creatinine when getting congested, right? Or improvement in creatinine when getting decongested. Testani showed that those who show any dynamic changes, improvement in creatinine, I should show it like this, or decline in creatinine, actually are sicker patients. And probably those are the biventricular RV failure patients. And we're probably seeing this undulation at different time frames. Any change in creatinine is a sicker patient and may be associated with a sicker patient profile. Not to say what you're doing is creating this, it's the patient. And thus, this AKI concept we really need to tackle. I'm communicating with nephrology societies for us to consider decongestion or GDMT, such as MRA and ARNI or ACE inhibitors, as an exclusion for us not to consider this as AKI or cardiorenal syndrome. That's another concept. So this is not cardiorenal syndrome. Decongestion is not cardiorenal syndrome. The rise in creatinine you see with decongestion is not cardiorenal syndrome. And the rise in creatinine you see with MRA, ARNI, and ACE inhibitor or ARB is not cardiorenal syndrome. Neither of those are AKI. And rise in creatinine, shown on the left side, which is called as change in GFR, if accompanied with hemoconcentration, rise in hemoglobin, is associated with better outcomes. It may be a reflection of appropriate decongestion. Now we have these better markers, potentially hemoconcentration, as a surrogate of what's happening with the successful delta changes for decongestion. The problem, though, of what I told you is problematic because this is a very recent data by Savarese et al. Of what's happening in the real world. So it does have the discontinuation of the newer agents as well as the older agents. And this is across globally, 3 major countries, large number. So if you look at the discontinuation, the orange components of those bars, so the GDMT started, these are hospitalized heart failure patients, and then within 30 days, GDMT is discontinued. How often? 25 to 35 to 40%. Part of it is not affording it, having lack of access, and so forth and so on. But we see this with MRA, we see it with a lot because of those changes that we see in the creatinine and so forth. That plays a role. This is a huge issue. Trajectory of response to therapy is my step 4, as I said. We define this in our consensus pathway document by the ACC, saying, look at where the patient is going once you do the treatment. Those who are improving, you're good. There's stall or non-responsive therapy. That's the middle portion. And those who are actually actively deteriorating, you have to rescue these individuals. So I'm going to start now using the rescue concept. Why? We know from all the registries, real-world patients, about a third gain weight in the hospital. I mean, we're talking about not just lack of improvement, we're talking about worsening. So 1/3 of our patients are refractory. And you look at the delta changes to those hemodynamic quadrants, about 1/3 will be with residual congestion in the congestion. And then in the hyperperfusion, about 10%, 6 to 10% being refractory or worsened. In the clinical trials, if you look at what percentage were with worsening or refractory, it's somewhere between 1/4. But they vary. depending on the trial. So we did in the expert consensus pathway try to say, please, please look at what your patient's trajectory is happening during this journey of your hospitalization or your treatment, and please identify that that patient is not ready for discharge and you need to escalate. And these are my proposals for what I consider refractory. Failure to improve, requiring escalation, right? Worsening, getting worse. So remember, these were decompensated patients. Now they're getting even worse and requiring escalation. It's going to be IV or mechanical. And the last component, step 5, is lifelong trajectory of the patient. A patient that had a heart failure admission, let's say 12 months ago versus 4 years ago, and this is a second admission. So I started using, with my trainees, DHF squared within the last 12 months, meaning 2 admissions in the last 12 months is a bad sign, right? And we work hard, and yes, you optimize the GDMT, you decongest, you are trying so hard to change the trajectory, but this patient is still modifiable. Not to lose the concept of change the trajectory, because we have many opportunities with our GDMT, whereas this patient, DHF quadruple, in the last 6 months maybe, that is a very bad sign of we have lost the appropriate timing of dealing with just the oral GDMT. We still have time. Of course, we need to optimize the GDMT. If they're not on board, boy, yes, we need to intervene and make sure that these individuals have the GDMT and the CRT. But yes, we need to now talk about the VAD and the transplant. So this whole trajectory of what's happening, because nobody is looking at it in the ADHF world. The patient is treated as a snapshot in the hospital with those surrogates that I had mentioned to you, which you are all familiar with. So these concepts right now need to be put into the structure, infrastructure, the ICD-10 codes. That's how the cancer does. Cancer says metastatic or refractory, right? We need to be able to go into these concepts, or a tumor lysis syndrome. We need to start looking at these concepts rather than these episodic treatment concepts. Hospitalized heart failure, acute decompensated heart failure. Not every patient that's hospitalized is the same. This patient is different. What do the guidelines do? I have to admit, yes, we were limited in defining the phenotype. And therefore, we try to do our best with what we wanted to be intervened in the hospital. Hospitalization is a good episode by which certain things can be done. First step we said is, please continue the GDMT, please. It should be continued. Don't stop it for these arbitrary concepts, which is line 2. If you look at, this is only in the US guidelines. We put this in line 2. Patients experiencing a mild decrease in creatinine or a transient asymptomatic drop in blood. How often do you see a drop in blood pressure in heart failure patients? You actually should see it if the patient is coming hypertensive. And in most patients with ADHF or hospitalized heart failure patients, you will see a 20% reduction. This is the treatment that you see with standard care. But we're not talking about shock. Okay, so these individuals should not have suddenly withholding of the GDMT. So we're trying to put this in guidance to our clinicians. And I always get this question, oh, how about if the creatinine triples, quadruples? Yes, that's an end organ damage. That patient is probably shock or low perfusion. Don't miss that patient. But the concept of just these arbitrary number changes should not be the reason for withholding. And we are recommending initiation of GDMT during hospitalization once the hemodynamic stability is achieved. And we are also saying, please do not discontinue unless there is a true indication such as shock, and it should be reinstated and further optimized as soon as possible. We do have ample evidence that initiation is safe. Initiation of GDMT, guideline-directed medical therapy, the quadruple therapy, is safe and effective. effective with endpoint benefit. I'm not showing you all the data. The win ratios in the impulse trial with SGLT2 inhibitors, in the Pioneer data, all of which transform, all of which show benefit with initiation of newer agents such as ARNI or SGLT2 inhibition, as well as older agents such as ACE inhibitors or beta blockade pre-discharge. So in summary, my proposition to our reconceptualization for heart failure is getting the acute out of decompensation, focusing on the decompensated, embracing both the chronic patients who are getting decompensated as well as newly diagnosed acutely decompensation. It's the delta decompensation that requires the escalation of therapies that defines the heart failure. So patients with active deterioration, despite optimized heart failure treatment, who require intensified, escalated, urgent IV or advanced rescue heart failure therapies, not specified by the location or the acuity of presentation. And I also propose as a second subsequent step, define congested or hyperperfusion and treat accordingly. And define the specific etiology, that's a third step, the proximate cause, so that you could target therapy to the specific cause, recognize biventricular or RV versus LV, recognize the confounding presentations that can hijack your ability to treat, such as refractory congestion, diuretic resistancy, and recognize the trajectories, the chronic trajectories, as well as the acute trajectories. So you can rescue if refractory or worsening, and you could escalate with a care coordination entailing higher levels of care if the patient's life trajectory is implying an active deterioration.